Hello, everybody. This is Dr. Radialis from the Georgia office. Today, I'm not talking about any specific subject. I always like to discuss a few cases that have been interesting in the last few weeks. But mostly, this is about your questions and if you have anything that you would like to share with the group. Um, One of the things that I would like to share is that this week we had our first spontaneous pregnancy after a testicular PRP, and that was extremely exciting. This is a young couple, 28, 29-year-old, where it was a severe male factor. And we started him on supplements, and he did one testicular PRP, and that resulted in her getting pregnant the following month. So we are very excited about that and some of the preliminary data that we're getting on testicular PRP. The idea behind it is that it works similar to the ovarian PRP, and it can be done outpatient since the male gonads, so the equivalent of the male ovaries, are exteriorized. So it's a lot less invasive than the ovarian PRP. And it seems from the preliminary data that we've been gathering that it works very well. So congratulations to the couple, and we're sending them a lot of love. Um, Another subject, and I'll be jumping around again. I didn't really pick a subject for this particular session, so you're always welcome to jump in and ask any questions that you might have. The other case that I thought was very interesting is recurrent fibroids. So I've had 3 cases in the last 2 weeks of ladies that have had recurrent fibroids where today I saw one of my, postoperative patients where I did a fibroid removal 6 months ago and I took out 40 fibroids, which was kind of crazy. So I did recommend for her to wait 6 months before transfer. And when she came in for her baseline about a month ago, to both of our surprises, she already had a fibroid that was impending in the cavity and 4 centimeters in its largest diameter. And when I did surgery on her last week, I actually took out 12 fibroids. And this is somebody that I had taken 40 6 months ago. So that is like crazy. That's like they grew really fast. And she has been the third one. I did surgery on Tuesday on a beautiful lady, and it was a myomectomy. I'm sorry, it was a hysteroscopic myomectomy. That means that the fibroid was removed from the inside the uterus. And then she was like telling me, I don't know what am I doing, that this is the third of the same procedure that I've had in less than 2 years. So I wanted to talk a little bit about that scenario and the plan that I did for these 3 ladies. Um, One, we do have to do an anti-inflammatory diet. Fibroids, same thing as all of the different inflammatory processes in the pelvis, adenomyosis, endometriosis. Um, it's a inflammation process. Okay, so I did, emphasize to remove anything from their diet that could be inflammatory, especially grains, especially nightshades, peanuts, cashews, beans, eggplant, etc. Also, with the lady that I saw today, luckily she already has her embryos frozen, so we will put her on Lupron to potentially shrink whatever tiny fibroids could have been left inside that I couldn't, take out or see. And again, decrease any inflammation in the pelvis. And then enzyme therapy, serapeptase, bromelain, again, to kind of dissolve whatever's in there. On my post-op today, we did intrauterine PRP to help that lining heal, as well as the muscle of the fibroid, because I did a high volume. and meditation. Okay, in the alternative world, and remember, I practice very holistic, so we want to approach it in different angles. In the alternative world, fibroids are condensed negative energy towards self as a woman. So the three of them I put to do positive affirmations. Okay, I'm beautiful, I'm great, I'm fertile, I'm young, and to do meditations to try to bless that energy center, okay, that area, to try to release some of that negativity that could be stored in their uterus, because the uterus is our identification as women. So all that negative self-talk that we have towards ourselves, I can, I'm too old, I'm too fat, I'm too this, I'm too that, all that negative thoughts, it's like swallowing poison, and the body, it's going to take the poison and kind of hold it in places to protect the rest of the body. So in the alternative world, you know, fibroids are associated with negative self-talk in relationship to your femininity. Okay, so I did put them on a very um, you know, all around program. So I wanted to kind of share that with you. But I've seen that you guys have been jumping with a few questions, so I'll go ahead and answer. Could you speak a little about reciprocal IVF success with CNY? My wife and I just had our consultation. Um, and none of the CNY people receive is inclusive of reciprocal IVF. So reciprocal IVF is a very common thing that we have at CNY. There are many ways of doing it. A lot of times it is literally reciprocal. I've had couples where they're actually pregnant at the same time. You don't have to be. And it could be that you know, one lady donates, the other one carries. That is considered reciprocal IVF, or both donate and both carry. Okay, and it could be done at the same time, or it could be kind of one first and then the other one. Success rate for IVF across the nation is 50%. So it's going to really depend on your age, on your overall health, any previous health conditions that could be impairing your ovarian reserve or the health of your uterus. At the time, I have a beautiful couple from Miami that I've been working with for about 3 years, and they're trying to do reciprocal IVF. The recipient, okay, she has endometriosis, so that's one of the challenges, and she does have low ovarian reserve. So her wife is the one donating, but they're trying to see if she can carry before the donating wife is just going to carry herself. So you see, it's like it gets a little more complicated. Okay. So we have Miss Hilda, and she's saying that she is doing all the medication. She's going to do a IUI, and she has two dominant follicles, one on each ovary, and then she's having pelvic pain. That is very common. Even with just having one lead follicle, because the ovaries are more stimulated than usual, even the other follicles, like they tend to swell up, and that can cause a lot of discomfort and a lot of pain. That does not mean that you're going to have ovarian hyperstimulation syndrome. That's kind of part of the process. Okay. And then the other stuff that you're mentioning, and I've heard of like just excruciating pain from the Ovidrel, because Ovidrel is like forcing ovulation. So then you have ovulation pain to the max. And then if you're ovulating from both ovaries, then you're going to have generalized pelvic pain. So, you know, you can do ice baths, you can do Motrin, you can do Tylenol, and just take it easy. Same thing, migraine is just your estrogen levels going up. I have a 5-day blast. I peaked Sunday. Usually ovulate 40 hours from my peak. I'm doing a complete natural cycle, no trigger. I personally Don't like doing completely natural cycles for frozen embryo transfer because the chances of missing the window, it's high. And the ideal scenario is that we can really manipulate the time of ovulation. So when I personally do natural cycles for frozen embryo transfer, I like doing modified natural. So I will give some letrozole to provoke ovulation. I will monitor, use Cetrotide or Ganirelix as needed, then use a trigger so I can know exactly that you will ovulate 36 hours later so we can start the progesterone. And then we can, make sure that we don't miss that window, because with the embryo transfer, as you all know, it's very critical, and it will be critical even, in a window of 3-4 hours. So if you ovulate and you're sleeping, you're gonna miss the window for sure. What is your opinion of mini IVF versus full IVF? So I personally prefer mini IVF across the board. I think it works better. It is kinder on your body, and you save a lot of money, And I have not seen that very high dose IVF does any good. All that said, there's always exceptions of women that are going to be very resistant to the medicine, but that's a very small group of people. Mini IVF is fantastic because it works really good on the decreased ovarian reserve ladies. They do better on mini, and then the younger crowd or PCOS in general will do better on mini IVF as well. Okay. So Lisa's 44, and she's having very good results with her IVF, because she got 12 eggs and then 18 eggs. That's 18 that fertilized yesterday. So she's doing a dual stim. And she's asking whether she should stop retrievals, and if she has a good chance of any of sticking at this age. I would have to kind of discuss your case a little bit more in depth with you. But if you're getting 12 eggs and 18 eggs out of a retrieval, chances are that you're going to get some eggs in there that will be good quality and will create decent embryos. In older ladies, I do prefer to prime them. Actually, I prefer to prime everybody, but in older ladies, I do prefer to prime them to optimize success rate. And I personally like doing fresh on decreased ovarian reserve and 40 plus. Okay. But yes, Lisa, I think that you have a good chance that you get that rainbow baby. I'm 40. I conceived naturally, but had a miscarriage. I'm sorry to hear that. And your gynecologist suggested IUI to get your cycle back. I mean, you can do IUI. That's no problem. That will not necessarily get your cycle back. That has nothing to do with it. And in terms of supplements, you always in my book, the minimum that anybody should be taking is a good prenatal vitamin. I have a few personal favorites. Make sure that it's a food-based. There's a few out there. There's the one that I recommend, which is from Nutritional Frontier. There's Garden of Life that can be obtaining Amazon. Sprouts and Whole Foods have really good multivitamins, food-based as well. And then a vitamin D. Then I would do some glandular therapy. I like a company called Standard Process, and I usually put people on something called a female endocrine pack because it's easy and it has kind of all the good stuff that I like to put people on. And PRP, it's amazing. It can do, like I started this saying, we have our first spontaneous testicular PRP baby. I have a lot of experience with it. I've been using PRP for over 12 years in different parts of the body, and I am a believer and a user. Any recommendations of tips right after a transfer? Pray. I recommend people not to travel day of transfer. I know that, sometimes you have to do it, because if it's going to implant, it's going to implant in that first 12-hour window. And I would just take it very easy, a lot of self-love, be in the right state of mind, relax, etc. When in reality is we don't really know, especially if you're going to fly, what are the effects of change in bariatric, pressure and pregnancy and stuff like that, especially right after a transfer. That's my opinion. Okay. Is a natural transfer for FET an option in Syracuse? Yes, it is. Um, Essentially, there are two protocols for an FET. Okay, you can do a natural transfer. Okay, that means an ovulatory cycle transfer or a medicated transfer. What's the difference between the two? The medicated transfer has been traditional, the default across all the IVF clinics, is a suppressive type of transfer, meaning you give estrogen in high dose to build up the lining and suppress ovulation, and then switch over to progesterone. That type of transfer, it is a suppressive and hormone replacement type. While the natural, you're going to ovulate on your own, and then you will be making progesterone, and then the progesterone we give is supplementary. Okay, it's not completely replacement. Then on the natural, then you have the modified natural, which is my personal favorite, where you actually are, triggering. You can trigger on your own, or you can do ovulation induction and then trigger. Okay, and all of the options are available at any of the CNY facilities that have embryology, okay, or have IVF. Okay. My clinic is closed on Sundays. They suggest me to do a transfer this Sunday. I would do a Monday transfer. It is shown that it is a little better to have a little bit more progesterone on board. And in general, we do more progesterone than less progesterone. Okay. So a day 5, we usually do 6 days of progesterone. So if you have a day 5 blast, just go ahead and put it in on Monday. When doing a frozen transfer, when doing a frozen transfer, when you shouldn't ovulate on your own at any time, because we have to know exactly when to put the embryo in. And the way that we do that is either by completely suppressing ovulation and manipulating your progesterone, or by knowing exactly when you ovulated and then counting the days thereof and supplementing the progesterone accordingly. So Nicole had a baby just on metformin, so I imagine your PCOS. If you want to add some inositol, CoQ10, I was telling the vitamin D, the good prenatal, keto. I mean, just if you want to keep it very basic, just keto diet, especially in a PCOS patient, would be huge. And then you can move up to oral ovulation induction and time intercourse, and all the way to IVF, but you might not need that much. All right. Okay. Hello to everybody. Hello. I'm glad that you're joining me tonight. All right, so Jennifer is saying my retrieval is Friday. I only have 120 millimeter. Okay, so Jennifer, it's going to depend on your ovarian reserve and what are we dealing with. I had this conversation with a beautiful lady today. Her AMH is 0.2, and she only has 1, potentially 2 follicles that could produce an egg. So if that is your case, then yes, we have to put all of our money on that follicle. Things that can be done. I mean, you can trigger that follicle and do IUI if your tubes are open, or just time intercourse. And then if you don't get pregnant, we can try to see, we can optimize your protocol and your baseline. That's going to be really important to have a true baseline with all the follicles around the same size, low FSH, low LH, normal, thyroid, and a normal low estrogen level. Any advice for somebody with a unicornate uterus? Is your tube open, Samara? That's going to be important, okay? I mean, not because you have a unicornate uterus means that you absolutely need IVF. If your tube is open, we can definitely work with that. Unicornate uterus or bicornate uterus or didelphys uterus means that the space in the uterus is not as much as a regular size uterus. So most of ladies that have this variants can get pregnant on their own. They're just at higher risk of fetal malposition, meaning higher risk for C-section, preterm labor, and smaller babies. So I would treat your uterus just like a small uterus. We could do PRP, we could do glandular therapy for the uterus to try to help it accommodate that baby longer. And then if that tube is open, just work with that side mostly, okay? So what blood work will determine if you're ovulating or not? Traditionally, it's a day 21 progesterone. Anything higher than 3 is considered ovulatory. Anything above 10 will support a pregnancy. So Miss Jennifer, you're 45 and your AMH was 0.78. So we can definitely optimize the situation. What I do with my 40 plus ladies is I get them to do a few cycles with letrozole and time intercourse, or if their tubes are tied, just letrozole, to get them to have very good ovulation, to optimize the baseline PRP. I can't say it enough. Supplements, NAD. So we do IV infusions with vitamins and NAD, glutathione, etc. So I have a full like anti-aging protocol for the 40 plus to try to get them pregnant. So, I would do that. I would probably just trigger that one follicle, not necessarily go through the whole retrieval. If your tubes are open, just have sex at home. And then we can do like a real, 2-3 month priming and get you to have a better success rate. With an AMH of 0.78, we can be ambitious and hope for 5, maybe 6 eggs. All right. And maybe somewhere between 2, maybe 3 embryos. All right. It's pretty close to 1. So that's pretty good for 45. Wondering what cycle day are egg retrievals. Egg retrievals are usually somewhere between 9 and 11 days after you start medication. So that means that if you started your medication on day 3 of your cycle, 10 days later is day 13. So give or take, it'll be around when you normally ovulate, somewhere between day 12 and day 14 of the cycle. Okay. I've had 2 live births, but 4 second trimester losses. Yeah, second trimester losses. Lovenox, I would probably suggest that you have progesterone until 36 weeks. I actually co-managing an IVF patient. She's been my patient for over 10 years, so my GYN patient. And she did bunch of IUIs, like 5 IVFs with us, ended up doing donor egg, but decided to go back to her country to do donor eggs. And her last transfer, the doctor where she was doing her therapy, ended up putting 3 embryos that took, and she came to me at 25 weeks and she was having contractions. And I just put her on progesterone, just progesterone until 36 weeks, discussed it with her MFM who was okay with it. And she is still pregnant with triplets at 29 weeks. And she said as soon as she was put back on the progesterone, contractions stopped. So that's what I would do with you, Samara. I would treat you as a preterm laborer, especially with your unicornuate uterus. And if you had to live birth, you just need to quiet that uterus, not so much the Lovenox. For those of you that need to reach me, my name is on the screen. Okay, I'm Dr. V as in victory, and V as in vagina, because we are claiming victory in the vagina. And you can send me a message through Messenger. I'm very easy to find, and I'll make sure somebody gets you on the book. Otherwise, the number in Atlanta is 770-266-3930. That is connected to the call center, so if they don't answer right away, it'll go to the call center, but you can always ask to be bounced back to the Atlanta office. Okay. And then one more question. Do you recommend priming with 6 units? So I imagine of human growth hormone for 90 days. It'll depend on the case. Human growth hormone, it's good for certain cases, not everybody. If you have endometriosis, if you have history of PCOS, if you have history of cancer, adenomyosis, please no human growth hormone. And the way I like to use it, and that is just part of my priming. I have a very robust protocol for priming. I use it Monday through Friday, Saturday, Sunday off, because hypothalamic and pituitary type hormones are pulsatile. So I use it Monday through Friday, give a break to the receptors Saturday, Sunday, so they get resensitized, and we hit it again on Monday. Okay. Atlanta is not doing retrievals and transfer yet. Let's see. I mean, the plan has changed a few times, and I know we've had some crazy years with the COVID and so forth. But the last thing I heard, it is in the plans for the end of this year. So let's cross our fingers. Okay. Well, very good. It was always a pleasure to have some time with you online. You're always welcome to, again, reach out to me through Messenger. You can look me up, Maribel Verdiales. I have a page for my patients. And then I will see you guys in 2 weeks. And next week it'll be in Spanish, all right? So have a blessed rest of your week. Bye-bye.